pen fell from her hand. It clattered against the marble table, once, twice, before rolling off the edge and onto the hospital floor. I didn't move to pick it up. Neither did he. She was sitting upright in the visitor's chair outside the consultation room, her signature still wet on the divorce papers spread across her lap. Her ex-husband stood beside her, his hand frozen mid-reach toward the documents. He was staring at her face. She wasn't crying. She wasn't speaking. Her lips were parted, her breath shallow and quick, and her right hand was pressed flat against the center of her chest. "Emily?" His voice cracked. She didn't answer. Her eyes stayed fixed on something distant, something none of us could see. The fluorescent lights above us hummed softly, casting pale shadows across her face. A bead of sweat traced a line down her temple despite the air conditioning that kept the hospital corridors at a constant 68 degrees. Then, in a voice so quiet I almost missed it, she whispered, "My chest hurts." He moved before I did, before anyone did. His chair scraped backward, the sound echoing down the empty hallway. His hands reached for her shoulders, steadying her as her body began to sway slightly to the left. But what we uncovered in the next 60 minutes wasn't a broken heart. It was something far more dangerous, something that would challenge everything I thought I knew about the intersection of emotion and physiology, about the invisible ways our bodies betray us when our minds push too hard, too long, too far beyond what we were built to endure. My name is Dr. Noah Reyes, and I'm a first-year resident in internal medicine at St. Halstead Hospital. It was a Thursday afternoon in late September, the kind of day where the sunlight slants gold through the hallway windows and the air smells faintly of antiseptic and coffee, with just a hint of the autumn leaves that were beginning to turn orange outside. I'd been on shift since 6 that morning. 11 hours of labs, consults, and the endless parade of patients whose stories all blended together in a tapestry of human suffering and resilience. My feet ached in my sneakers. My white coat felt heavy across my shoulders, but I was alert, caffeinated, and ready for whatever came next. That's what I told myself anyway. I was finishing up a chart review at the nurse's station when I heard the commotion near the elevators, voices rising, footsteps echoing fast across tile, the sharp intake of breath that signals something wrong, something urgent, something that demands immediate attention. I glanced up from my laptop screen. A man was half carrying, half guiding a woman through the double doors that led into the ER wing. She was pale, ghost pale, the kind of pallor that speaks of shock, of blood retreating from the surface to protect the vital organs deep inside. Her legs moved stiffly, mechanically, like she was walking through water or moving in a dream where the world had gone thick and slow. Her blouse was wrinkled, a cream-colored silk that probably looked elegant that morning but now hung askew, one side untucked from her charcoal slacks. Her hair, dark brown, shoulder length, hung loose over one shoulder, strands sticking to the sweat on her neck. Behind them, a security guard jogged to keep up, holding a manila folder and a pair of reading glasses that must have been dropped in whatever chaos had erupted upstairs. "Sir, you can't just..." the guard started. "She needs help," the man snapped, his voice raw with an urgency I recognized immediately. Not anger, fear. "She needs help now." I moved toward them before I'd consciously decided to move, my instincts kicking in before my thoughts could catch up. This is what they train you for in medical school. The ability to shift from neutral to emergency response in the span of a heartbeat, to recognize when someone's life is balanced on the edge of a knife. Dr. Kavita Patel, the attending on shift, was already striding across the floor from the other side of the ER, her white coat billowing behind her like a cape. She was in her mid-40s, with sharp dark eyes and a reputation for being simultaneously the most demanding and the most brilliant physician in internal medicine. "What happened?" she asked, her tone calm but commanding, the kind of voice that cuts through chaos and creates instant order. The man looked at her, then at me, then back at the woman in his arms. His hands were shaking, not trembling but actually shaking, like he was holding something too heavy for too long and his muscles were giving out. "We were signing papers," he said, the words tumbling out in a rush. "Divorce papers, at the mediator's office upstairs. And then she said her chest hurt and she couldn't breathe and her face went white and I didn't know what to..." "Bring her in, Doctor," Patel interrupted, her voice crisp and efficient. She gestured toward the nearest exam room. "Room 3, now." I followed them inside, my mind already running through differential diagnoses. Chest pain in a woman. Could be cardiac, MI, angina, pericarditis. Could be pulmonary, PE, pneumothorax, pneumonia. Could be GI, GERD, esophageal spasm. Could be anxiety, panic attack, hyperventilation, but something in my gut told me this wasn't anxiety. The woman, Emily, I'd learn later, was guided onto the examination bed. She sat stiffly, her spine straight, her hand still pressed against her sternum. Her breathing was fast and shallow, her nostrils flaring slightly with each inhale, her chest rising and falling in rapid, insufficient movements. Dr. Patel snapped her fingers at me. Reyes, vitals, EKG, move. I nodded and grabbed the blood pressure cuff from the wall mount, wrapping it around Emily's left arm. Her skin was cool to the touch, slightly damp with perspiration. I pressed the stethoscope to her inner elbow and pumped the cuff, watching the mercury climb and then slowly descend. BP's 140/95, I said, keeping my voice level despite the concern rising in my chest. Elevated, but not dangerously so, within the range of stress response. Dr. Patel was already pulling on latex gloves with practiced efficiency, the snap of the material sharp in the small room. Heart rate? I placed 2 fingers against the radial pulse point on Emily's wrist. Her pulse was rapid, thready, uneven, like a drum pattern that kept skipping beats. 110, irregular. Dr. Patel's eyes narrowed behind her glasses. She leaned in close to Emily's face, studying her pupils, her skin color, the slight bluish tinge beginning to appear around her lips. Emily, can you hear me? Emily nodded, but her gaze stayed unfocused, locked on some point in the middle distance that existed somewhere beyond the walls of this room. Can you tell me where the pain is? Dr. Patel asked, her voice gentler now, coaxing. Emily's lips moved. Her voice came out in a whisper, barely audible over the ambient noise of the ER beyond our closed door. Here, she tapped her chest lightly with 2 fingers, right in the center of her sternum. It's tight, like someone's sitting on me, like there's a weight. She trailed off, her breathing becoming more labored. Dr. Patel straightened, her expression shifting into what I'd come to recognize as her combat mode. Focused, decisive, absolutely controlled. Get the EKG, she said to me, and call cardiology. Tell them we might have an MI, myocardial infarction, heart attack. The words sent a jolt of adrenaline through my system. I turned and moved fast toward the door, already pulling my phone from my pocket. The EKG machine rolled into the room with a soft mechanical hum, its wheels squeaking slightly against the linoleum floor. I positioned it beside the bed and began placing the electrodes across Emily's chest, my hands steady despite the adrenaline pumping through my veins. I'd done this hundreds of times in medical school, thousands if you counted the practice sessions on mannequins and classmates. But there's always a different weight to it when the person beneath your hands is actively dying, when every second counts, when the difference between correct electrode placement and sloppy work could mean missing a critical finding. The sticky gel was cold. Emily flinched slightly when the first electrode made contact with her skin, just below her right clavicle. I worked quickly, methodically, right arm, right leg, left leg, then the 6 precordial leads across her chest in a specific pattern that would give us a 3-dimensional view of her heart's electrical activity. Dr. Patel stood beside me, her arms crossed, her eyes locked on the monitor as the first reading began to appear. The machine beeped. Lines appeared on the screen, black against white, jagged peaks and valleys representing the electrical impulses that should be coordinating the steady, rhythmic contraction of cardiac muscle. Should be, but weren't. ST elevation, Dr. Patel said quietly, leaning closer to the monitor. Her finger traced one of the abnormal peaks. Leads 2, 3, and AVF. My stomach tightened. ST elevation, the ST segment of the EKG waveform rising above the baseline, was a red flag. A signal that part of the heart muscle wasn't getting enough oxygen. A sign that cells were dying. The classic signature of a myocardial infarction. But something didn't fit. Her age, I murmured, half to myself, my eyes moving from the monitor to Emily's face and back again. Dr. Patel glanced at me. What? She's young, I said, nodding toward Emily. Mid-30s maybe? No obvious risk factors. No obesity. No visible signs of chronic illness. No xanthomas suggesting high cholesterol. I looked at her hands. No nicotine staining on her fingers. Her build was slender, athletic even. Her skin tone was healthy beneath the pallor of acute distress. Young women don't have heart attacks. That was the statistical truth hammered into us in epidemiology classes. The risk rises after menopause, after decades of accumulated damage from hypertension, diabetes, smoking, sedentary lifestyle. This didn't make sense. Doctor, Patel's expression didn't change, but I saw the brief flicker of acknowledgement in her eyes. She'd noticed the same thing. "Heart attacks don't check ID, Reyes," she said, her voice flat. "And atypical presentations are more common in women than men. Run a troponin panel and get me a chest x-ray. Now." I nodded and turned toward the door, but something made me pause. The ex-husband was still standing in the corner of the room, his hands gripping the back of a chair so tightly his knuckles had gone white. His jaw was clenched, the muscles working beneath his skin. And his eyes were red, not from tears, but from something else. Exhaustion, fear, and underneath it all, guilt. The kind of guilt that sits heavy in your chest and makes it hard to breathe. "Sir," I said quietly, stepping toward him, "I need to ask you some questions." "Do you know if she has any medical history? Any conditions we should be aware of?" He blinked, as if surfacing from deep water, as if my voice was pulling him back from whatever dark place his mind had gone. She's been stressed. We've been fighting for months. The lawyers, the paperwork, the arguments about who gets what and who deserves what and who did what to whom." His voice cracked. He took a shaky breath. "I thought she was just tired. I thought the headaches were from stress, the exhaustion, the way she couldn't sleep anymore." He looked at me, his eyes desperate. "Is she going to die?" I wanted to tell him no. I wanted to offer reassurance, to say the things doctors say when they need to keep family members calm. But I'd learned early in my residency not to make promises I couldn't keep. "We're doing everything we can," I said instead. "But I need you to think carefully. Has she complained of any chest pain before today? Any pressure? Any tightness?" He hesitated, his brow furrowing. She mentioned her shoulders hurting a few weeks ago, and her jaw. Said it felt sore, like she'd been grinding her teeth at night." He paused. "She said it was stress." Dr. Patel's head snapped toward him. "Her jaw?" He nodded. "Jaw pain, shoulder pain, fatigue, atypical presentation. The kind of symptoms that get dismissed as stress or anxiety or overwork, especially in women, especially in the absence of the crushing central chest pain that textbooks describe. The kind of symptoms that are actually a heart attack in slow motion." Dr. Patel looked at me, and I saw the shift in her expression, from concerned to urgent. "Reyes, get cardiology down here. Page Dr. Okafor directly. Tell him we have a possible STEMI in a young female with a typical presentation and several weeks of prodromal symptoms. STEMI, ST elevation myocardial infarction. Time is muscle. That's what they taught us. Every minute of delay means more heart tissue dying, more permanent damage, more risk of catastrophic complications." I ran. The hallway was a blur of white walls and fluorescent lights as I sprinted toward the nearest phone. My fingers fumbled with the receiver as I punched in the code for the cardiology department. "Cardiology, this is Jensen. This is Dr. Reyes from the ER, I said, trying to keep my breathing steady. "I need to page Dr. Okafor for an emergent consult. Possible STEMI, female, mid-30s, ST elevation in the inferior leads, atypical presentation." There was a pause. "Did you say mid-30s? "Yes." "Confirmed ST elevation?" "Confirmed. I'll page him now. Give me your callback number." I rattled off the extension for room 3 and hung up. My hands were shaking slightly, not from fear but from the adrenaline, from the weight of knowing that the next few minutes would determine whether Emily walked out of this hospital or whether we'd be the ones calling her family to deliver the worst news of their lives. I jogged back to the exam room. Through the small window in the door, I could see Dr. Patel adjusting Emily's IV line while a nurse, Maria, one of the veterans who'd been working ER for 20 years, drew blood for the lab panel. I pushed through the door just as Emily let out a soft gasp. "The pain," she whispered. "It's getting worse." Dr. Patel's jaw tightened. "On a scale of 1 to 10, how bad?" 8, maybe 9. Emily's face was contorted now, her features twisted in agony. "It's spreading. Down my left arm, up my neck. Classic radiation pattern. This was real. This was happening." Dr. Patel turned to Maria. "Give me 325 milligrams of aspirin chewable and prep sublingual nitroglycerin." Maria moved with the efficiency of long practice, pulling medications from the crash cart. The aspirin went in first. Emily chewed it mechanically, her face grimacing at the chalky taste. Then the tiny nitroglycerin tablet placed under her tongue. "This might give you a headache," Dr. Patel warned. "It dilates your blood vessels." Emily nodded, her eyes squeezed shut. I watched the monitor. Heart rate still elevated, blood pressure holding steady, oxygen saturation at 94%. lower than ideal, but not critical. The phone on the wall rang. I grabbed it. "This is Dr. Okafor," came the deep voice on the other end. "I'm in the cath lab finishing up a procedure. What have you got?" I gave him the rundown: age, presentation, EKG findings, vital signs, the prodromal symptoms that had been dismissed as stress. There was a long pause. "I'll be down in 3 minutes," he said finally. "Get her on a heparin drip, and someone needs to get a detailed history, family cardiac history, any autoimmune conditions, recent pregnancy, use of oral contraceptives, anything that might explain this." "On it," I said. He hung up. I turned to the ex-husband, who was still standing in the corner like a ghost, like he wasn't sure he was allowed to exist in this space anymore. "I need to ask you more questions," I said. "About Emily's medical history," he nodded mutely. "Does she have any family history of heart disease, parents, siblings, grandparents?" He thought for a moment. "Her dad had high blood pressure, but he was in his 60s when it started. Her mom's healthy as far as I know." "Any autoimmune conditions? Lupus, rheumatoid arthritis, anything like that?" "No, nothing like that." "Has she been pregnant recently? In the last year?" His face darkened. We tried 3 years ago. She had a miscarriage at 12 weeks. We didn't try again after that." I made a mental note. Pregnancy loss can sometimes be associated with underlying vascular conditions. "Is she on any medications? Birth control pills? Hormone therapy?" "No birth control. She stopped taking it after the miscarriage. Said she didn't see the point anymore." His voice was hollow. Dr. Patel was listening while she worked, her hands moving efficiently as she started the heparin drip. "What about smoking, alcohol, recreational drugs?" The ex-husband shook his head. "She doesn't smoke. Never has. She'll have a glass of wine sometimes, but not often. And no drugs." "Exercise habits?" I asked. "She runs, or she used to, 3-4 times a week, 5 miles at a time." He paused. "She stopped a few months ago. Said she was too tired. Fatigue. Exercise intolerance. More pieces of the puzzle." The door burst open and Dr. Okafor strode in, still wearing his surgical scrubs, a blue cap covering his close-cropped hair. He was a tall man, broad-shouldered, with the kind of presence that immediately commanded respect. He moved straight to the EKG monitor, his eyes scanning the tracings with practiced speed. "Inferior wall STEMI," he said, his voice clipped and clinical. "Possible right ventricular involvement. How long since symptom onset?" I checked my watch. "Approximately 20 minutes since she presented. But she's been having prodromal symptoms for weeks." Dr. Okafor's eyes narrowed. He turned to Emily, his expression softening slightly. "Emily, I'm Dr. Okafor, the cardiologist. We're going to take you upstairs for a procedure called a cardiac catheterization. We need to look at the blood vessels in your heart and see what's blocking them. Do you understand?" Emily nodded weakly, her lips now distinctly blue despite the oxygen cannula we'd placed in her nose. "Am I going to die?" she whispered, her voice barely audible. Dr. Okafor didn't flinch. He'd probably heard that question 1,000 times in his career. "Not if we can help it," he said firmly, "but we need to move fast." He turned to the team. "Call the cath lab, tell them we're coming up, and get an echo down here. I want to see if there's any wall motion abnormality before we go in." Everything happened at once. Maria was on the phone, coordinating with the cath lab team. Another nurse was prepping the ultrasound machine. Dr. Patel was adjusting medication dosages, her fingers flying across the touchscreen of the IV pump. I stood back, feeling suddenly useless, watching the choreography of emergency medicine unfold around me. The ex-husband grabbed my arm. "What's happening? What are they doing?" I turned to him, forcing myself to focus. "They're preparing her for an emergency procedure. They're going to insert a catheter into an artery, probably through her wrist or groin, and thread it up to her heart. Then they'll inject contrast dye and take X-ray images to see where the blockage is. And then they'll try to open it, either with a balloon or by placing a stent, a tiny metal scaffold that holds the artery open." He was pale. "Is it dangerous?" I wanted to lie. I wanted to tell him it was routine, that people had this done every day and walked out fine, but I respected him too much for that. "There are risks," I said quietly. "Bleeding, infection, stroke, damage to the artery. In rare cases, the heart can be injured during the procedure, but the risk of doing nothing is much higher. Without blood flow, the heart muscle dies, and once it's dead, it doesn't come back." He absorbed this, his face crumbling. "This is my fault." "No," I said firmly. "This isn't—" "We were fighting," he said, his voice breaking. For months, screaming at each other, saying terrible things. I told her she was the reason our marriage failed. I told her she was cold, that she didn't know how to love anymore. Tears were streaming down his face now, and she just took it. She took all of it and kept going to work and kept taking care of things and kept pretending everything was fine. And I never asked if she was okay. I never asked if she was hurting. I didn't know what to say, because maybe he was right. Maybe the stress had contributed. Maybe the endless cortisol, the sleepless nights, the emotional battering had weakened something inside her that was supposed to stay strong. But I also knew that blame wouldn't save her. You brought her here, I said finally. When it mattered most, you brought her here. You might have saved her life. He looked at me with red-rimmed eyes and nodded slightly, but I could see he didn't believe it. The echo tech arrived with the portable ultrasound machine. Dr. Okafor squeezed gel onto the transducer and pressed it against Emily's chest, angling it to get different views of her heart. On the screen, I could see the grainy black and white image of her heart chambers contracting and relaxing, but one section of the wall, the inferior wall, was moving wrong. Hypokinetic, barely moving at all. Definite wall motion abnormality, Dr. Okafor muttered. Let's go. They unlocked the bed's wheels and began rolling Emily toward the door. The ex-husband tried to follow, but a nurse gently caught his arm. You'll have to wait here, sir. There's a waiting room on the 4th floor, outside the cath lab. Someone will come get you when she's in recovery. He stood frozen in the doorway, watching as Emily disappeared down the hallway, surrounded by the medical team that was now solely responsible for keeping her alive. I watched him sink into the chair beside the now empty bed, his head in his hands, his shoulders shaking. And I realized something I hadn't been prepared for in medical school, that sometimes the hardest part of medicine isn't the procedures or the diagnoses or the long hours. It's witnessing the aftermath of all the small wounds people inflict on each other, day after day, until something inside them breaks. I left the ex-husband in the exam room and walked back to the nurse's station, my mind still churning through the details of Emily's case. Mid-30s. No significant risk factors. STEMI presentation with atypical prodromal symptoms. Something wasn't adding up. Dr. Patel was already at the computer, pulling up Emily's lab results as they began to populate in the system. Troponin's elevated, she said without looking up. 12.3. Normal troponin, a protein released when heart muscle is damaged, should be near 0. Anything above 0.04 is concerning. 12.3 was astronomical. CBC? I asked, leaning over her shoulder. Normal. White count's fine, hemoglobin's 13.2, platelets are adequate. Lipid panel? Dr. Patel scrolled down. Total cholesterol 185, LDL 102, HDL 63, triglycerides normal. I frowned. Those were actually good numbers, not the profile of someone who should be having a heart attack. Inflammatory markers? I suggested. Dr. Patel clicked through to the extended panel we'd ordered. CRP is elevated, 10.8. C-reactive protein, a marker of inflammation in the body. Normal is less than 3. 10.8 suggested something inflammatory was happening, but it wasn't specific enough to tell us what. What are you thinking? Dr. Patel asked, finally looking at me. I'm thinking this doesn't look like typical atherosclerotic disease, I said slowly. Young woman, good lipid profile, no smoking history, regular exercise until recently, but she's got clear evidence of acute coronary syndrome. Dr. Patel nodded. Okafor mentioned SCAD on his way out. Spontaneous coronary artery dissection. I'd read about SCAD in textbooks but had never seen a case. It was rare, accounting for only about 4% of acute coronary syndromes overall, but much more common in younger women. Instead of a plaque rupturing and forming a clot, the artery wall itself tears, creating a false lumen that blocks blood flow. What causes it? I asked. That's the million-dollar question, Dr. Patel said. It's associated with pregnancy and the postpartum period. Hormonal changes affect the arterial wall integrity, also linked to extreme physical exertion, emotional stress, fibromuscular dysplasia, connective tissue disorders. The ex-husband said she had a miscarriage 3 years ago. Dr. Patel looked at me sharply. That's potentially relevant. Pregnancy-associated SCAD can occur during pregnancy or up to 12 weeks postpartum, but some studies suggest women who've had it have ongoing vascular vulnerability. And the emotional stress, I added. 6 months of contentious divorce proceedings, constant fighting, sleep deprivation. Dr. Patel leaned back in her chair. The body keeps score, Reyes. You can only push it so far before something gives. I thought about Emily's face, the exhaustion written in the lines around her eyes, the defeated slump of her shoulders even before the pain hit. A woman who'd been running on empty for months, ignoring every warning sign her body sent because there was no time to stop, no space to acknowledge weakness, until her body made the decision for her. "What's the prognosis with SCAD?" I asked. "Depends on how extensive the dissection is and whether they can restore flow," Dr. Patel said. "Conservative management is often preferred if possible. Let it heal on its own. But if there's significant compromise to the vessel or high-grade stenosis, they might need to place a stent. And after? High risk of recurrence. Some studies show up to 30% of SCAD patients have another event within 10 years. She'll need careful follow-up, stress management, probably beta blockers and antiplatelet therapy." I absorbed this information, feeling the weight of it. Emily's life had just fundamentally changed. Even if she survived this, even if the cath lab team successfully restored blood flow and she walked out of the hospital, she'd be living with the knowledge that her body could betray her again at any moment. That stress wasn't just an emotional burden, it was a physical threat. "Go check on the husband," Dr. Patel said, turning back to her computer. "And then I need you to follow up on the Henderson admission in room 7. Possible pneumonia." I nodded and stood, but hesitated. "Dr. Patel?" "Yes?" "How do you tell the difference between someone who's genuinely in medical crisis and someone who's just overwhelmed?" She looked at me for a long moment. "You don't always know," she said finally. "That's the honest answer. Sometimes anxiety and heart attacks look identical. Sometimes people having panic attacks get worked up with full cardiac panels and imaging, and it's all negative. Sometimes people get dismissed as anxious and they're actually dying. So what do? You listen," she said simply. "You listen to what they're saying and what they're not saying. You look at the whole picture, not just the labs and the EKG, but the person in front of you, their story, their life." She paused. "And when you're not sure, you err on the side of caution, because you can always apologize for overreacting, but you can't bring someone back from the dead." I thought about that as I walked back toward the exam room where the ex-husband was still waiting. You listen. Such simple advice. But in a medical system that gave us 15 minutes per patient, that measured our productivity in RVUs and patient throughput, that rewarded efficiency over empathy, listening had become almost revolutionary. I found the ex-husband exactly where I'd left him, sitting in the chair with his elbows on his knees, staring at the floor. "Mr. Harmon?" I said gently. He looked up. His eyes were raw. "I'm going to head up to the waiting area," he said, his voice hoarse, "in case they need me." "That's a good idea," I said. "But before you go, can I ask you something?" He nodded. "Emily's symptoms, the shoulder pain, the jaw pain, the fatigue, did she see a doctor about any of that?" He thought for a moment. "She went to her primary care doctor about a month ago, complained about being tired all the time. They ran some blood tests." "Do you know what they found?" "Said everything was normal. Told her she was probably depressed. Suggested an antidepressant." I felt a familiar frustration rising in my chest. How many times had I heard this story? Woman presents with vague symptoms. Tests come back normal. Diagnosis: anxiety, depression, stress. Prescription: antidepressants, therapy, yoga. All potentially helpful interventions. But not if the real problem is your heart is slowly dying. Did she mention the shoulder or jaw pain to the doctor? He shook his head. "I don't think so. She probably thought it wasn't important. Or she'd learned that when women complain of too many symptoms, they get labeled as hypochondriacs, as difficult patients, as attention-seeking. Better to stay quiet. Better to push through until you can't anymore." "Mr. Harmon," I said carefully, "what you're feeling right now, the guilt, the sense that you should have known, should have done something, that's natural. But I need you to understand something. The medical system failed Emily too. She sought help. She was told she was fine. This isn't all on you." He looked at me with something like gratitude, but the guilt didn't leave his eyes. "I should have been kinder," he said quietly. "Even if we were getting divorced, even if we couldn't make it work, I should have been kind." I had no response to that, because he was right. We should all be kinder. He stood slowly, like his bones ached, and gathered the manila folder that held their divorce papers. "I'll be in the waiting room," he said. I watched him walk away, his steps heavy, and wondered what it felt like to carry that kind of regret. An hour passed in the particular kind of suspension that exists in hospitals. Time moves differently here. Minutes stretch into hours during emergencies. Hours compress into moments when you're trying to complete notes before your shift ends. I moved through my other patients mechanically. An elderly man with pneumonia who needed IV antibiotics. A teenager with a laceration that required sutures. A woman in her 50s with poorly controlled diabetes and a foot ulcer that smelled of infection. Normal ER fare, the bread and butter of emergency medicine. But my mind kept drifting back to Emily, somewhere upstairs in the cath lab, her life hanging in the balance while a team of specialists threaded catheters through her arteries and tried to repair what stress and biology and bad luck had torn apart. I wondered if she was awake. They usually gave conscious sedation for cath procedures, enough to keep you calm and pain-free, but not so much that you were completely unconscious, which meant she might be aware, in a dreamy, disconnected way, of what was happening to her body, of the tubes invading her vessels, of the dye flooding her heart, of the careful manipulation of instruments that could save her life or catastrophically end it. I finished suturing the teenager's laceration, a clean cut above his eyebrow from a skateboarding accident, and was washing my hands when Maria found me. "Dr. Reyes?" Dr. Okafor called down. "The procedure's done. He wants to talk to Dr. Patel, but said you could come up if you wanted to observe the patient in recovery." My heart jumped. "She's okay?" He didn't say much, just that the procedure was complete and she's stable. Stable. In medical terminology, that word could mean a lot of things. It could mean she was fine, on the road to recovery, or it could mean she was alive but critical, balanced on a knife's edge. I found Dr. Patel reviewing images on one of the ER computers. "Maria said Okafor called?" She nodded without looking up. "Procedure's done. He's calling with the full report in a few minutes. You should go up to recovery if you want to see her." I hesitated. "Is that appropriate? I'm not on the case officially." Dr. Patel finally looked at me. "You were the first person to take her vitals when she came in. You helped stabilize her, and I suspect you could use the learning experience. Go. Just don't get in the way." I didn't need to be told twice. I took the elevator to the 4th floor, my mind racing through possible outcomes. Best case, they'd found a single discrete dissection, placed a stent, restored full flow. Worst case, extensive dissection, unable to intervene, medical management only. The cardiac recovery unit was quieter than the ER, with dimmed lights and the soft ambient beeping of multiple monitors. A nurse directed me to Bay 3. Emily was there, lying in a hospital bed that seemed too large for her frame. An IV line ran into her left arm. Cardiac monitor leads snaked out from beneath her hospital gown, connected to the screen above her bed that showed her heart rhythm in real-time green tracings. Her eyes were closed, her face slack with the remnants of sedation, but she was breathing steadily on her own. No ventilator, which was a good sign. A blood pressure cuff was wrapped around her right arm, automatically inflating and deflating every 15 minutes. And sitting in the chair beside her bed, holding her hand, was her ex-husband. He looked up when I entered. "Dr. Reyes," he said, his voice rough. "How is she?" I asked quietly. "They said the procedure went well. They found the tear and put in a stent. Dr. Okafor said she was lucky. Another 20 minutes and..." He couldn't finish the sentence. I nodded, moving closer to check the monitor. Heart rate 72. Blood pressure 120/75. Oxygen saturation 98% on room air. Beautiful numbers. "Has she woken up yet?" "A few times, just for a minute or two. She's confused, keeps asking what happened." I looked at Emily's face, peaceful in sleep, and felt an unexpected surge of emotion. Relief, yes, but also something deeper. A kind of awe at the resilience of the human body, at its capacity to survive even when pushed past all reasonable limits. "You stayed," I said to the ex-husband. He looked down at Emily's hand in his. "Where else would I be?" It was a fair question. "The divorce papers," I said. "What will you do about those?" He was quiet for a long moment. "I don't know," he said finally. "We signed them. Legally, the process is in motion, but..." He trailed off. But I sat in that waiting room for an hour thinking about what I'd say if she didn't make it. What I'd tell people at the funeral. How I'd explain that the last thing I said to her before she collapsed was that I was glad we were finally done with each other. His voice broke on the last word. And I realized that I don't want that to be the end of our story. I don't want the last chapter to be about resentment and lawyers and dividing up furniture. Even if we can't be married anymore, even if we've hurt each other too much to go back, we can at least be kind. I thought about what Dr. Patel had said. The body keeps score, but so does the heart, the emotional heart, the one that remembers every wound, every moment of cruelty, every time someone who was supposed to love you chose to hurt you instead. "That's good," I said quietly. Kindness is good. Emily stirred slightly, her eyelids fluttering. Her hand tightened around her ex-husband's fingers. "David?" she murmured, her voice thick with sedation. "I'm here," he said immediately, leaning closer. "I'm right here." Her eyes opened slowly, unfocused and confused. "What happened?" "You had a heart attack," he said gently, "but you're okay now. The doctors fixed it." She blinked, processing this information with the slow deliberation of someone whose brain was still half submerged in pharmaceutical fog. "A heart attack? The artery in your heart tore. They put in a stent. You're going to be fine." She was quiet for a moment, her eyes drifting closed again. Then so softly I almost didn't hear it. "I'm sorry." David's face crumpled. No, don't apologize. You have nothing to be sorry for." "I ruined everything," she whispered. "You didn't ruin anything." "I did. We both did." He raised her hand to his lips and kissed her knuckles gently. "But we're going to do better. I promise." I felt like an intruder in this moment, witnessing something too intimate and raw. I stepped back quietly, preparing to leave them alone. But as I reached the curtain, Emily's eyes found mine. "Doctor?" she said. I turned back. "Yes?" "Thank you," she said, "for helping me." "You're welcome," I said. "But you did the hard part. You listened to your body. You asked for help." She gave a weak smile. "Barely." "But you did," I insisted. "That matters." She nodded slightly and her eyes drifted closed again, exhaustion pulling her back down into sleep. I left the recovery bay and nearly collided with Dr. Okafor in the hallway. He was still in his surgical scrubs, pulling off his cap to reveal sweat-dampened hair. "Dr. Reyes," he said, "you came to check on our patient? I hope that's all right." "More than all right. You helped save her life." He gestured toward the nurse's station. "Walk with me. I'll show you the images." We moved to one of the computer terminals where he pulled up the catheterization images. The screen filled with ghostly black and white images of Emily's coronary arteries, highlighted by radio-opaque contrast dye. "Look here," he said, pointing to a section of artery that showed an irregular narrowing. "This is the left anterior descending artery, the LAD, what we call the widowmaker, because blockages here are often fatal. You can see the dissection. The tear in the arterial wall created a false lumen that compressed the true lumen and blocked blood flow." I leaned closer, studying the image. You could actually see it, the dark shadow where blood had infiltrated between the layers of the arterial wall, creating a second channel that didn't belong. "What caused it?" I asked. "That's always the question with SCAD," Dr. Okafor said. "In her case, I'd put my money on a perfect storm of factors. She has mild fibromuscular dysplasia. We saw some beading in her renal arteries on the imaging, which is a classic sign. That makes her arterial walls more vulnerable to tearing. Add in chronic emotional stress, elevated cortisol levels, probable sleep deprivation, and you've got a recipe for disaster. The miscarriage she had 3 years ago, could that have contributed?" Dr. Okafor nodded. "Pregnancy causes significant vascular remodeling. The hormonal changes, the increased blood volume, the mechanical stress on the arterial walls, all of that can unmask underlying vulnerabilities. And some studies suggest that women who have pregnancy complications have higher rates of cardiovascular disease later in life. So she was a ticking time bomb, in a sense, but the fuse was lit by stress." He clicked to another image, this one showing the stent in place, a tiny metal scaffold holding the artery open, restoring the flow of blood. "We got lucky. The dissection was focal, not extensive. We were able to place a drug-eluting stent without complications. If it had extended further, or if she developed a hematoma that compressed the entire vessel, we might be having a very different conversation. What's her prognosis? Good, with proper management. She'll need dual antiplatelet therapy for at least a year, aspirin and Plavix to prevent clot formation on the stent, beta blocker to reduce cardiac workload, regular follow-up with echocardiography to monitor heart function, and critically, stress reduction." "How do you prescribe that?" I asked. Dr. Okafor smiled grimly. "You don't. You can only recommend it and hope the patient takes it seriously. Therapy, meditation, yoga, cutting back on work hours, resolving toxic relationships, whatever it takes. Because the statistics are clear. SCAD patients who don't manage their stress have significantly higher recurrence rates." I thought about the divorce papers, still sitting somewhere in that manila folder. "She and her husband were signing divorce papers when she collapsed," I said. Dr. Okafor's eyebrows rose. "Well, there's your stressor." "But he stayed. He brought her in, stayed through the procedure, and he's in there now holding her hand." "People are complicated," Dr. Okafor said. Relationships are complicated. Love and harm aren't mutually exclusive. Sometimes they're so intertwined you can't separate them. He closed out the images and turned to me. Your job isn't to judge their relationship. It's to fix what's broken in the body and give them a chance to fix what's broken between them, if they choose to. He clapped me on the shoulder. Good work today, Dr. Reyes. You have good instincts. Trust them. He walked away, leaving me standing alone in the hallway, thinking about broken things and second chances. I saw Emily twice more during her hospital stay. The first time was the next morning, during rounds. She was sitting up in bed, looking more alert, eating Jell-O from a plastic cup while a physical therapist evaluated her mobility. Dr. Reyes, she said when she saw me, her face brightening. They told me you were the one who called the cardiologist. Dr. Patel made the call, I said. I just helped. Well, thank you anyway. She set down her Jell-O. They said I almost died. I chose my words carefully. You had a serious event, but you got help in time. Because David brought me in. She looked toward the window where her ex-husband stood with a cup of coffee, talking quietly on his phone. He saved my life. You saved your own life by telling him something was wrong, I corrected gently. A lot of people ignore those symptoms. They convince themselves it's nothing. You didn't. She was quiet for a moment. I was scared, she admitted. When the pain started, I thought, this is it. This is what a heart attack feels like. And all I could think was that I didn't want to die in a lawyer's office, signing papers that said our 12 years together meant nothing. David ended his phone call and walked back to her bedside. His hand found hers automatically, their fingers intertwining with the ease of long habit. We talked, Emily said, looking at me, about everything, the fighting, the resentment, all the things we did to hurt each other. And, I asked, and we're still getting divorced, she said simply. Because the problems that broke us in the first place, those haven't changed. We want different things. We've grown into different people. David nodded in agreement, his expression sad but calm. But we're going to do it differently, Emily continued. With mediation instead of litigation. With respect instead of revenge. We're going to remember that we loved each other once, even if we can't love each other the way we need to now. I felt something loosen in my chest. That sounds healthy. The cardiologist told me stress could kill me, Emily said with a wry smile. So I'm choosing not to let it. No more screaming matches, no more weaponizing lawyers. We're going to be adults about this, and we're going to be friends, David added quietly. Eventually, maybe not right away, but eventually, I thought about all the divorced couples I'd known, my parents' friends, classmates' parents, relatives who'd split in bitterness and never spoken again. The ones who used their children as messengers, who spent decades nursing grudges, who let resentment poison every memory. This was different. This was choosing healing over harm. I think that's brave, I said honestly. Emily squeezed David's hand. It's practical, she said. Life's too short to spend it being angry. She was right, of course, and she'd learned it the hardest way possible. The second time I saw Emily was 3 days later, on her discharge day. She was dressed in regular clothes, jeans, and a soft sweater, and she was sitting in a wheelchair per hospital protocol, even though she was perfectly capable of walking. David stood beside her, holding a bag with her discharge paperwork and medications. I found them in the lobby, waiting for David to bring the car around. Dr. Reyes, Emily said warmly. I was hoping I'd see you before I left. How are you feeling? I asked. Tired. A little sore, but alive. She smiled. They gave me about 1,000 instructions. Rest, don't lift anything heavy, take my medications, follow up in a week, call immediately if I have any chest pain or shortness of breath. Are you going to follow them? Every single one, she said firmly. I'm also starting therapy and yoga, and I'm taking a leave of absence from work. That's good, I said. Your heart needs time to heal. So does the rest of me, she said quietly. David returned, keys in hand. Cars out front. As the nurse began wheeling Emily toward the exit, she turned back to look at me. Dr. Reyes, can I tell you something? Of course. When I was on that table in the cath lab, half sedated but still aware, I kept thinking about what I'd regret if I didn't make it. And you know what topped the list? I shook my head. Not the trips I didn't take or the career goals I didn't achieve. It was the time I wasted being cruel. To David, to myself, to people who didn't deserve it. She paused. I don't want to waste any more time like that. Then don't, I said simply. She nodded, smiled, and let the nurse wheel her away. I watched them leave, Emily in the wheelchair, David walking beside her, not quite touching but present, there, a steady support even as they prepared to separate their lives. And I thought about what Dr. Okafor had said. Love and harm aren't mutually exclusive. Sometimes the kindest thing you can do for someone is let them go. Sometimes the bravest thing you can do is walk away from what's hurting you, even if you once loved it. Sometimes survival means recognizing that your body is sending you messages in a language you've been ignoring for too long. Pain, exhaustion, the tightness in your chest that isn't just emotional anymore. The body keeps score, and eventually it demands payment. That evening, after my shift ended, I sat in my car in the hospital parking lot, too tired to drive home, but too wired to sit still. The autumn sun was setting, painting the sky in shades of orange and pink that seemed too beautiful for a day that had contained so much near-death and raw emotion. I pulled out my phone and opened my notes app, where I'd been keeping a running journal of my residency. Observations, lessons learned, moments that struck me as significant. I started typing. Today I learned that heart attacks don't always look like the textbooks say they will, that women's symptoms are different, more subtle, easier to dismiss, that a sore jaw and tired shoulders and persistent fatigue can be your heart screaming for help in the only language it knows. I learned that stress isn't just an emotional burden, it's a physical threat. That chronic elevation of cortisol can weaken arterial walls, trigger inflammatory processes, set the stage for catastrophic failure. That you can't fight with someone for months on end, drown in resentment and sleepless nights and cortisol storms, and expect your body not to pay the price. I learned that the most important question we can ask isn't, what are your symptoms, but what's your story? Because Emily's story wasn't about cholesterol or blood pressure or family history. It was about a marriage falling apart, a miscarriage that left scars no one could see, a woman who kept pushing through pain because she thought that's what she was supposed to do. I learned that healing isn't always about reconciliation. Sometimes it's about learning to let go with grace, to choose kindness over being right, to recognize that you can love someone and still need to leave them, that the opposite of love isn't always hate. Sometimes it's simply incompatibility. And I learned that the body keeps score, that it remembers every slight, every stress, every moment you ignored its warnings, that eventually it will force you to listen. It will shut down non-essential functions and demand that you pay attention, that you rest, that you acknowledge that you are not in fact invincible. The body keeps score, and eventually it demands payment. I stopped typing and looked up at the sky, watching as the colors deepened from pink to purple to that particular shade of blue that exists only in the moments between day and night. Somewhere in this city, Emily was settling into her home, taking her medications, maybe looking at her ex-husband across the kitchen table and seeing him not as an enemy, but as a fellow human being who'd also been hurt, who'd also made mistakes, who was also trying to figure out how to move forward without destroying what little goodness remained between them. Somewhere, a heart that had been torn was beginning to heal, supported by a metal scaffold and antiplatelet drugs and, hopefully, a new commitment to being kind, if not to each other, then at least to herself. And somewhere in my own chest, my own heart beat steadily, reliably, taking for granted the miracle of its own function, while my mind raced ahead to the next shift, the next patient, the next crisis that would demand everything I had to give. I started the car and drove home, thinking about broken things and second chances, about the invisible ways we hurt each other and ourselves, about the body's capacity for both catastrophic failure and miraculous healing, and about the profound truth that sometimes the most radical act of self-care is simply choosing to stop fighting. With others, with yourself, with the truth of what your body needs to survive. 6 months later, I was working a night shift in the ER when I saw a familiar name pop up on the patient board. Emily Harmon, scheduled follow-up cardiology appointment. I felt a jolt of concern. Was she back because of complications? Another event? But when I looked up, I saw her walking through the ER lobby toward the cardiology wing, moving steadily, looking healthy. She was carrying a folder and wearing athletic clothes, running shoes, leggings, a light jacket. She didn't see me, and I didn't call out to her. This was her private medical appointment, and I had no role in it. But I couldn't help following her progress through the glass doors, watching as she checked in at the cardiology desk and took a seat in the waiting area. She looked good, better than good. There was color in her cheeks, energy in her movements, an ease in the way she sat that suggested the weight she'd been carrying 6 months ago had finally been set down. I turned back to my own work, a steady stream of coughs, sprains, infections, the normal chaos of ER life. But my mind kept drifting back to Emily. I wondered if the divorce had been finalized, I wondered if she and David had managed to maintain that fragile peace they'd forged in the aftermath of crisis. I wondered if she'd continued with the therapy, the yoga, the conscious choice to prioritize her own healing over everything else. Later that night, during a rare quiet moment, I pulled up her chart. Not the current visit, just her discharge summary from 6 months ago. Follow-up echocardiogram at 3 months. Normal left ventricular function. No wall motion abnormalities. Stent patent and functioning well. Stress test at 4 months. Negative for ischemia. Exercise tolerance normal. Medication adherence. Excellent. Psychological evaluation at 2 months. Patient reports significant improvement in stress levels. Continuing with weekly therapy. Has implemented lifestyle changes including regular exercise, meditation, reduced work hours. Social history update. Divorce finalized. Patient reports amicable separation. Minimal ongoing conflict. I closed the chart and felt something like pride. Even though I'd played only a small role in her recovery, Emily had done the work. She'd taken the warnings her body had screamed at her and actually listened. She'd made the hard choices to leave a relationship that was killing her, to prioritize rest over productivity, to choose kindness over righteousness, and she'd survived. Not just survived, she was thriving. That's what medicine is really about, I thought. Not the dramatic saves in the cath lab or the perfectly executed procedures. It's about giving people a chance, a second chance, a chance to do things differently, and then stepping back and trusting them to take it. I think about Emily often, even now. I think about the pen falling, the whisper, "My chest hurts." The moment when everything that had been building for months finally came to a head. I think about the invisible toll that stress takes on the body, the way cortisol floods your system and never quite recedes, the way inflammation smolders like a fire you can't see until it's consumed everything, the way arterial walls weaken under the constant assault of elevated blood pressure and lack of sleep, and the particular toxicity of chronic resentment. In medical school, they teach you about risk factors: age, genetics, smoking, obesity, diabetes, hypertension. But they don't always teach you about the risk factor that might be the most dangerous of all, the slow grind of daily stress that you can't escape, that you wake up with and fall asleep with and carry through every hour of your day until your body simply can't take it anymore. The body keeps score. I've seen it again and again in my residency. The executive with the bleeding ulcer, the teacher with the autoimmune flare, the parent with the stress-induced cardiomyopathy. Bodies breaking under the weight of lives that have become unbearable. And the tragedy is that we normalize it. We wear our exhaustion like a badge of honor. We compete over who's more burned out, who gets less sleep, who's sacrificed the most, until something breaks, until the pen falls and the whisper comes, "My chest hurts." And then, if you're lucky, if you're very lucky, someone hears you. Someone brings you to the hospital. Someone runs the tests and makes the call and gets you the help you need. And you get a second chance. Not everyone gets that chance. I've seen the ones who don't, the ones who ignore the symptoms until it's too late, the ones who collapse at home, in their cars, in places where no one finds them in time. Emily was lucky, but she also made her own luck by speaking up, by asking for help, by choosing, in the aftermath, to actually change her life instead of just returning to the patterns that had nearly killed her. That's the part they don't show you in medical dramas, the aftermath. The hard work of recovery that happens outside hospital walls, in therapy offices and yoga studios, and quiet moments of choosing yourself over the expectations that nearly destroyed you. That's where the real healing happens. I finished my shift that night and walked out into the cool spring air. 6 months had passed since that September afternoon when Emily collapsed in a lawyer's office. 6 months of seasons changing, of life continuing, of the steady forward march of time that waits for no one. The hospital would still be here tomorrow. There would be more heart attacks, more emergencies, more moments of crisis where everything hung in the balance. But there would also be moments of recovery, of discharge days and follow-up appointments where the news was good, of second chances taken and lives rebuilt. That's what I hold on to on the hard days. The knowledge that sometimes we get it right. Sometimes we catch it in time. Sometimes the story doesn't end in tragedy, but in transformation. Sometimes the pen falls and the whisper comes and we actually listen. And in that listening, in that moment of paying attention to the body's desperate plea for help, sometimes we save a life, not through heroics or brilliant diagnoses or cutting-edge procedures, but through the simple act of taking someone seriously when they say, "My chest hurts." Sometimes the bravest thing you can do is admit you're breaking. Sometimes the kindest thing you can do is let something go. Sometimes the wisest thing you can do is listen to the language your body speaks before it's forced to scream. The body keeps score, but it also keeps giving you chances to listen, to rest, to heal, to choose differently. Emily chose differently, and she lived. That's not just medicine, that's hope.